really great to be here. It's always a pleasure to come talk to the group. And my wife is going to text me any scoring updates that go on my phone right here. So if I get distracted, you know why. And I guess they're not using pucks tonight at the game. I guess they've got the hamburgers stacked at the side boards. So we're missing a good show, I think, I hope. So I want to talk to you tonight. Actually, when I first agreed to do the talk, I thought maybe we'll talk about the new active surveillance guideline that's been put on the CCO website to be published probably in June in the Canadian Journal. But I also saw that since that time, on February 28th, CCO has released some documents on their website about PSA and screening, and obviously that's near and dear to this group's heart. We were a little chagrined to read through some of those documents, but there's some good stuff and some bad stuff in it, and I'm going to take you through those and maybe hit the highlights. So this is actually, I'm quoting myself. Normally people put a quote from somebody else, but I think this is, I really believe that this is true, and I think in my talk tonight I'm going to try to have everybody understand what we mean by this. I think if we're going to preserve the upfront end of this thing, we don't have PSA screening as such, but if we're going to still see men in a non-metastatic state or an earlier state to treat so that we can still try to cure people, I think we really have to embrace active surveillance. So really I think you're all seeing the tide of policy is really anti-PSA. We've seen the US task force come out strongly against PSA, basically saying don't use the test. The Canadian task force, as was just mentioned, came out in the fall saying virtually the same thing. It was sort of lockstep with them, and it was a frustrating process because our organization, the Canadian Urological Association, actually was asked to participate in those talks. So we had members go to that group and do some of the teleconferences and face-to-face discussions. And it was really just a token request because nothing that we said ever made it into the final document. So it became a bit of an acrimonious process. So they basically just echoed and mimicked the US statement. And we'll take a look at the CCO stuff that just came out February 28th. Medical training is also very anti-PSA. We have family medicine residents rotate through with us in the clinics on their elective rotation in urology so that they can understand a bit about prostate cancer and what they have to know as a family doctor. And what they're being taught in medical school and in residency is very anti-PSA as well. So I think we're really up against it here to some degree. So I think this problem has really been brought about by a number of things. So we as physicians treating prostate cancer patients, I think have dropped the ball over the years a bit. I think some of the groups, such as yourselves, who tend to be vocal and lobbying for screening, as much as we're all well guided in that, I think we've maybe overdone it. I think the pendulum has swung too far because most of the guidance, if you read the details in these statements, most of the anti-PSA stuff comes from the harms that come from screening men with low-grade cancers. So that's really what I'm going to talk about tonight. So the guys here who have high-grade cancers, been treated, not to worry, this is not really directed at you as such, not directly. This is really for the newly diagnosed guys who have low-grade disease, and I think we need to understand that we can manage this disease better overall. So those harms are really what has brought about this anti-PSA sentiment. It's not actually a problem with the PSA test itself. It's a problem with over-diagnosis and over-treatment and therefore harms. There's clearly good evidence of benefit if you have intermediate and high-risk prostate cancer. So those of you who may have had Gleason 7 disease or 8 or 9 and had treatment, again, this is really not about your case specifically. Clearly there's benefit to treating those cancers and those patients benefit from it. Clearly there's benefit to finding those cancers, and that's why we really don't agree completely with these guideline statements that CCO has put out, US Task Force, Canadian Task Force. I think there's a middle ground here where we can still screen in a smart way without having to screen everybody. And the other key thing is to uncouple a diagnosis of prostate cancer from treatment. Back, 10 years ago, when we found any little bit of prostate cancer, that guy would almost always go on to treatment. And now we've uncoupled that. And I think this surveillance guideline really goes a long way towards that, helping us with that uncoupling. So there's clearly good evidence for treating prostate cancer, no question about it. The critical thing that we've learned over the years is that pure Gleason 6. So if you don't know what Gleason 6 means, Gleason scale is a grade scale that was designed by a pathologist named Gleason about 40-odd years ago. And it's held up over all this time. It's kind of an odd scale in that it goes really from 6 to 10 now. So 6 is the lowest grade. So if you're diagnosed with Gleason 6 only nowadays, you're really a candidate for active surveillance, and we'll go through that a little bit more. But we've learned that perhaps Gleason 6, if it's pure Gleason 6, may not really act like a true cancer in the true sense of the word. And in fact, there's some movement afoot to perhaps change the name of Gleason 6 away from cancer and call it something else. I'm not sure that's going to get traction. There are a lot of debate in the literature and amongst urologists and uropathologists about that. But it might be coming that we no longer call this cancer. So one of the reasons that I've sort of laid out some of the reasons that we believe this. There's a lot more than this. If you can look at a lot of the sort of basic science stuff, you look at the actual cells and their behavior and how they stain very differently from Gleason 7 cancers. But really, if you look at some of the evidence that it's not a lethal condition, when we look at autopsy studies where the guy died for some other reason, the prostate's removed, it's carefully sectioned, we find only Gleason 6. We really have never had any cases where at autopsy there have been metastases found at the same time. So those, again, that's when you have the prostate out, either in an autopsy or after surgery, you really know the true state of that prostate. You know that it has exactly the grade of cancer it has. If it only has 6, that's different than a prostate cancer, a prostate that contains some 6 and some 7 or some 8. Very different thing. And if we look at a very large study that looked at 14,000 radical prostatectomy surgeries where when they finally get the prostate out and could examine it very closely and they found only 6 in the gland, there were no cases where there was cancer also in the lymph nodes. So really no documented case of metastases to lymph nodes or elsewhere in a pure Gleason 6. So there are issues with that, right? Because we don't have the prostate out when we first find somebody's cancer. We might have 6 on their biopsy, but we don't know exactly what else is going on. So that's really what active surveillance is all about. And again, no patients have been known to die from prostate cancer who only had 6 in their final specimen. So that there might be the odd one of you, if you've been around long enough, who would say, well, hang on a minute, that's not true. I had my prostate out in 1997 and it was pure Gleason 6, and I've been dealing with a recurrent rising PSA. So in 2005, the World Health Organization actually changed the way the Gleason score is read. And from that year on, many of the old 6s are now being called 7s. So that 6 that you had in 1997 and you've had a rise in your PSA and you had radiation, and you say, well, this guy's full of baloney up here tonight saying Gleason 6 can't do that. If you had that same diagnosis post-2005, you probably would be called Gleason 7. And we've seen that in practice. A patient not that long ago who had Gleason 6 when I took his prostate out many years ago. PSA was rising, much to my surprise. I was contemplating sending him for radiation therapy. Still didn't make sense to me. So I had our pathologist go back and look at that prostate again, and they call it clearly that that's a 7 in today's language. So I think there is, I think it's important to know that the behavior of pure Gleason 6 prostate cancer is indolent and probably not malignant. And more of the stuff on the right side. We don't have to go through that. I want to get on to the other information before too long. But when we look at the latest active surveillance series from Toronto, Sunnybrook, which is reporting now more than 10 years out, which is fantastic that we have this long-term data. They're showing that in patients who entered their surveillance program, the chance of dying from prostate cancer around 12 to 15 years is only about 3%. So you could say, okay, well, that's still 3% we don't want to die, but actually those numbers are very similar to the same guys if they all had surgery or all had radiation back 10 or 15 years ago. So it appears that long-term data on active surveillance is very similar in outcome for the low-grade prostate cancers as it would be if we had treated those guys aggressively up front. So this is just a screen capture. Much of my talk tonight is just screen captures from CCO website. So this is, I don't know if I have a pointer on this. Is the pointer in the middle? Is Chris, no, I'll check. Yeah, okay, good. All right, so you can see here, if you go to the CCO website, we have these position statements, and this is under resources for primary care providers. So this is where a family doctor will get their information if they want to go straight to CCO and find out what they should do with PSA. So we're going to go through the position statement that they've released, and this is as of February 28th. Key messages, questions and answers, and a decision grid. We don't have to go through the details of all this stuff, but I think it's important for you guys, because part of your mandate, I think, is to maintain awareness, similar to ours. Awareness, get tested, find it early. If you've got a bad cancer, get it treated early. And there's really no question in our minds that that's going to make a difference to people, and we know we save lives. And particularly with Gleason 7 and higher cancers. We don't cure everybody, but we do. There's very good evidence that we improve death rates from prostate cancer by treating those patients. So here's some of the stuff from CCO. So basically, key messages, they're essentially saying a guy at average risk, so this is somebody with no family history or other worrisome high-risk feature, avoid PSA testing. There's little to gain, they claim, in men over 70 or men with less than 10 to 15-year life expectancy. So I think that's a very reasonable statement, actually. We don't advocate screening for the first time in a guy who's over 70. If you've been having your PSA followed for a while and it's a little bit elevated and you follow through your 70s, that's a different story. We're not recommending a guy who's 75 just come in who feels great and get a PSA done. I think that really is probably off the table these days. So these are reasonable first opening statements. For men at increased risk, so they jump straight to increased risk without really dealing with men in what we would consider to be the age range, the target age range, sort of 40 to maybe 69 or 70. They just make the statement about the Canadian Task Force recommending against that screening. They talk about benefits. It's a little bit contradictory, this whole thing they've put on the website, but nonetheless, saying the greatest benefit from screening appears to be in men in these age groups. That's from the European screening trial that showed a 21% survival advantage to men who got screened between the ages of 55 and 69 compared to a control group that didn't get screened in the European trial. So I think there's a clear survival benefit in that study, that long-term randomized study. So men at increased risk, so then the next question is why not just take the guys at a high risk? Their father had it, their brother had it, they may be of African American descent or very strong breast cancer, family history. Some reason you'd think that this guy's at higher risk. And so they go through this stuff a little bit and essentially just say that there's insufficient evidence to recommend screening even in the high-risk patients. Although they do admit that the CUA and the AUA state that this should be a shared decision-making process. So I think the opening salvo here on their key messages is don't use PSA in virtually any setting. So if you've already had a PSA test, this is a very reasonable thing to do. So if you have a PSA less than 1 at age 60 on a screening test, we would agree with that. I don't think there's really probably any need to get any more PSAs done. Those guys really, there's good evidence to show that those guys are not at risk of dying from prostate cancer. They are at risk of having prostate cancer, but we don't necessarily want to find that prostate cancer because it's probably Gleason 6. or they may have a Gleason 7 at a later age that's not going to affect their survival. So that's a reasonable statement. This is less evidence-based, but I think if your PSA is still low at the age of 70, probably shouldn't be screened any further. So I think that's actually a very reasonable thing to say. They talk about risk calculators, and I think that's true. There are some good risk calculators out there. The problem is the numbers are kind of tricky. We use these in the Cancer Assessment Center. A guy gets referred in. We run them through a nomogram, and it tells us the percentage chance that they have any cancer, prostate, or high-grade prostate cancer. So we separate them because we don't really need to find any prostate cancer. The trouble is that you often end up with a number around 10 to 15% chance of having high-grade prostate cancer. And it's hard to know really what to tell a guy about that. To some people they'd say, okay, I've got a 14% chance of high-grade cancer, I would have to go through a biopsy, I might have treatment unnecessarily, potentially, and they might jump at that. They might say, yeah, look, let's do it, let's do the biopsy, let's sort this out, and next guy through, 14%, that's low, I'm good, I'll see you, never, I'll go follow up with my family doctor. So it's a very, the risk calculators are useful, but it's really difficult to know exactly what to do with those final numbers. So again, they talk about repeat screening, shared decision process. That's fairly reasonable. So those are really their key statements. So essentially, to me, when I read this, it just means don't use PSA at all. I think that's quite clearly what CCO is saying now. So we've tried to fight this a little bit. We've had our provincial lead talk to them about this, who works for CCO, and they really don't want to hear it. They're pretty set on this. They want to follow in the sort of the footsteps of the larger task force. So I think we're stuck with this kind of message from CCO and from the Ministry of Health for quite some time. So some questions and answers. I'm not sure there's a whole lot in here. They do make some odd statements. So what does Cancer Care Interior recommend for screening? And they go on to say that randomized controlled trials using PSA have shown a possible but small reduction in prostate cancer mortality. So I'm not sure why they say possible. I mean, this large European randomized trial showed a clear 21%. In fact, if you look at the data a different way, it gets up to about 28%. Though reduction in death rates. That's very similar to what we see with mammography, yet that has a screening recommendation and PSA does not. And I think it's because probably there have been fewer harms, still a fair number of harms with breast cancer screening, but fewer harms compared to prostate. They do make a statement that you should talk to your family physician. That's great. The problem is the new family physicians are being trained to not do PSAs. In fact, I'll see people not infrequently come to me who say, you know, my original family doctor just said they will not do it, period. So they went to another doctor and they got a PSA and they've made their way into the clinic. Why are they making this recommendation? So again, they go through, it's interesting that they didn't say possible small reduction in this line, they just say small reduction, but that may just be bad proofreading. Harms are common. So we're starting to see this harm issue become a major theme. And we'll keep moving on here. I don't want to keep repeating the same stuff. I think it's important you guys are aware of this stuff. So our men in Ontario being screened properly, they just say basically, given the harms associated with it, harms again, they don't recommend it. Talk about OHIP paying for it, you guys all know this stuff. People who are being treated and monitored, it's fine, it'll get covered. If we think you have a high risk, particularly a physical exam abnormality, but we can check the box if you've had multiple family members that have prostate cancer. So that will be paid for. Everybody else has to pay for their PSA. And they're basically just saying that no screening is planned by the Ministry of Health. Again, potential harms of treatment and screening. I think we'll just jump through this. This is more of the same stuff. So I'm going to move on to the guideline in a second. So I just wanted to say I think the reason these two talks fit together is that one naturally follows. So if these organizations who are setting the bar at stating that PSA should not be used are going to blame or credit all the harms for that recommendation, and we need to address the harms. And I think clearly in cancer treatment, harms are a necessity. In other words, if I'm treating somebody who's got a really advanced cancer, whether it's prostate or kidney or bladder or whatever, and their only chance of cure or survival is that they undergo a major operation or chemotherapy or radiation, then we balance the harms, the downsides, right? So if you could lose your bladder control, lose your erectile function, but if we don't treat you, you'll die from prostate cancer sooner, then I think the trade-off is probably reasonable. The issue is, though, if you take a guy with Gleason 6 cancer and you treat him, you still have those same potential harms, but it's really questionable these days what the benefit is. I mean, if we're not actually improving survival, like the stuff I showed you earlier on in Gleason 6, if we're not treating an actual cancer, it's a non-lethal condition, maybe even part of growing older, like gray hair and wrinkles, just to have some Gleason 6, because it's very common, and we're treating that, it could be pure harm, right? So if you're not saving someone's life, but you're causing them side effects, that's pure harm, no benefit. And I think that's what we've done for way too long. And I think that if we can address that issue, then we can be part of the pendulum slowing down a bit. And like everything else in medicine, usually we'll see the pendulum swing back the other way. It may not go as far as it did, but I think that we have a chance at recapturing some form of early detection with prostate cancer over the next 5 to 10 years. Because right now it's really getting away from us. You can see these recommendations are clear. You know, we're kind of beating our heads against the wall with these organizations, trying to convince them based upon the way things are. It's frustrating in Canada because many of these recommendations are based upon what's gone on in other parts of the world, such as the US, where today even though they're talking about active surveillance, I think they talk a good game, but they don't practice a good game. I think there's a lot of guys still having surgery for low-risk disease or radiation. When I say surgery, I mean any treatment for prostate cancer, who probably should be on active surveillance and are not. Part of it's driven by market forces in the US, maybe medical legal forces in the US. But in Canada, for quite a number of years, we've been practicing active surveillance. And it's not a perfect science, that's for sure. But I think if we don't go that way, we are going to lose early detection completely. Now, we're all hoping that there's going to be a better test come along that convinces people that we can start screening again with this new test, but that doesn't exist today. And all the stuff you hear and all the things you read about, you know, urinary PSA3 markers and all this other stuff, those are not the answer to the screening problem. So we don't yet have a better test. What we have to do is deal better with what we have today. So, in fact, that's what we've tried to do with this guideline with CCO. So this is done through McMaster. So this is part of the provincial evidence-based guidelines group. So it's actually, this is an internationally known methodology and group. It's not just a bunch of people that sit in a room and say, we think this is what should happen. It's a very stringent, rigid process that, a robust process that we go through. It starts with a systematic review of all the studies that exist in all of the literature. It's very exhaustive. All of these studies get weeded down by certain criteria until we see what we have left that can really try to guide us in what we do. And one of the big problems trying to do this active surveillance guideline was that we really don't have any randomized trials at this point. So, you know, the best evidence for something in medicine is a randomized trial where you sort people into a treatment versus some other treatment. In this case, it would be, say, surgery or radiation versus active surveillance, and then follow them for 10 or 15 years and see which group does better. It's been tried. There was a big trial started actually in Canada called the Spirit trial, which is now closed, where we tried to randomize men between surgery, brachytherapy versus an active surveillance kind of approach. Just didn't accrue. People didn't sign up for it, doctors didn't buy into it, and the trial died, which is unfortunate because that trial, that was quite a while, that was like 10 years ago that was initiated. So by this point in time, we might actually have had some better answers. We have no randomized data to guide us, so we just use the best quality data that we have. And so we really want to look at the low risk patients. So low risk and Gleason 6 are not necessarily the same thing. You have to have Gleason 6 to be low risk, but low risk implies that you also have a low PSA and not a big nodule on your rectal exam. So we really kind of stuck with the Gleason 6 patients here and didn't get involved too much in the rectal exam and the PSA levels, because those are those really cloud the issues a lot more. So what we came out with were 5 recommendations. So there's no point in going through all of the pros here. You can read through this document if you want. I think you'll actually find it readable. But our first and number 1 recommendation, which originally was a little controversial, I really wanted to push this through, so we kind of pushed it through some barriers. But we came out with agreement from our expert panel, and this has gone out to multiple expert reviewers before it's been published. And essentially what we're saying is that if you have low risk and really truly defined as Gleason 6 on your biopsy, that we feel that active surveillance is the preferred management approach. Whereas, 10 years ago, 15 years ago, this would be not considered for a guy who's 50 or 55. So the other thing that's important about this kind of guideline and our current approach is that we're no longer really just reserving active surveillance for guys who are diagnosed in their mid to late 70s, for example, with Gleason 6. If a guy see a guy who's 51 who's got a small amount of Gleason 6, I'll sit down with him and talk, but we will do active surveillance for that guy, because I'm really not convinced that he has a disease that's going to kill him, but we have to watch them closely. So that's the whole thing behind this sort of protocol. So this is our recommendation number 1. We think it's the preferred thing to do. We'll get to the protocol in a later recommendation, but I think just to have you get a little bit of understanding about active surveillance. So if you look at all the guys that originally have just Gleason 6 on their first biopsy, and you follow them over the years, you'll find about 30% of them will end up getting treated, up to 50% depending upon the series. So many of those men will never need treatment, and they will escape the harms of treatment for many years. Yes, active surveillance has its own potential harms, just in repeated biopsies and anxieties and a bit of a roller coaster ride for a lot of men. But we do avoid the major toxicities of treatment. If you go back to the days where we used to take all of these guys to the operating room and take out their prostate, you'll see that about 25% of them actually have Gleason 7 or higher. So it's kind of the wolf in sheep's clothing. So this is where we have to be careful, right? Because we're saying, look, Gleason 6 is not going to kill you, don't worry about it, everybody needs to go on active surveillance. But we know that at least a quarter of the guys that we consider a candidate for active surveillance have higher grade cancer in their prostate than what was originally shown. So the onus is now on us, if we're going to recommend active surveillance, to try to find that higher grade cancer so that we can treat that guy. And if it's not there, and the other 75%, don't treat them and follow them along and reassure them safely. So we'll get to that protocol and a little bit of sort of the latest thinking in the active surveillance world. So our recommendation number 2, we talked about treatment, and I think that treatment is clearly appropriate for patients with Gleason score 7. There is a very small subset of patients who probably can be treated with active surveillance if they have a very small amount of Gleason 7. And if the higher grade part of that is very small. But this is to be interpreted with great caution, this statement. This is a very small number of men. So the majority of guys who are healthy, who have longer than 10 to 15 year life expectancy, if they have 7, we're going to treat them. And studies show that we're going to have a good chance of helping those guys. But we still have a few guys that we can still watch with 3+4. But I think it's critical that this guideline establishes that we believe that treatment is appropriate for those in whom we think they have a real disease. So our third recommendation is really with the protocol. So this is really one of the more challenging things, right, is that nobody knows really what the best protocol is. And lots of centers have different protocols. For example, if you go to Johns Hopkins and you go on active surveillance there, they will do a repeat biopsy on you every year for 10 years. It's a lot of biopsies. And if we know that in Ontario, between 3 and 4% of men are hospitalized after a prostate biopsy, usually for infection, sometimes other things, retention, or some people get chest pain or something. But the majority of these are for infection. So if you're going to do a biopsy in a guy every year for 10 years, you're really exposing him to a lot of infectious risk. It's uncomfortable or painful. There can be several days of blood passing, blood in the stools, blood in the sperm for many, many weeks. You could say that's harmless, but it's a little traumatic to the guy when he stands there and he's peeing blood. So I think it's something we really want to try to minimize those numbers of biopsies. So that's kind of one end of the spectrum. If you look at the NICE, so NICE, which is kind of the UK guideline group, if you look at their active surveillance protocol that actually was just put up, they're really recommending a repeat biopsy, but then they leave it open-ended, that you don't really even need to worry about more biopsies. And we think that's a little bit too far the other way. So what we really incorporated here was kind of the Sunnybrook approach, and that is, we have the original diagnostic biopsy that shows this little bit of Gleason 6. We have the talk. We're going to repeat that biopsy within 6 to 12 months. The reason is, out of those 25%, remember I told you if you take all those guys to the operating room, take out their prostates, about 25% of them actually have higher grade disease. So by repeating their biopsy early, you will actually tease some of those guys out. And so you've only delayed them about 6, 7, 8 months. Probably not a big deal with this lower grade disease. And you now can tell the guy, okay, look, your repeat biopsy shows some 7, let's get ready, let's operate or radiate or do something to treat this because it's a real cancer. It's not exactly what we thought you had 6 months ago, but we kept a close eye on you. So that second repeat biopsy, I think, is a very important biopsy. If that is okay, and that's either going to show you no cancer, which doesn't mean your cancer went away, it just means that it was a small amount of cancer and the repeat needle shots didn't hit the cancer, which is good, because we actually want to sample other areas of the prostate, not just the same old Gleason 6 over and over again. It can be the same, so you might have had 2 cores, 5%, and now you've got 1 or 3 cores, 5%, we call that the same, or it could be something worse. So you've gone up in terms of maybe volume, maybe on your second biopsy, out of your 12 cores, you've got 8 that are positive with Gleason 6, and that's probably a marker for higher risk disease. Or you've actually got Gleason 7 or Gleason 8, and it's time to get on with it. So we do the repeat biopsy, and then if that's okay, we go to about an every 3 to 5 year interval as a rough guideline. So remember, these are guidelines, these are not written in stone. If your doctor feels that you need a biopsy again shorter than 3 years, then you can do it. It's just a guideline. It's just saying, look, you don't have to do one for 3 to 5 years, and that seems to be good. And that's based upon the Sunnybrook series that is now reporting the longest and best outcomes in the literature today in terms of long-term follow-up. So what we came up with, and we looked at everything in the literature, including other tests like PCA3, and basically we felt that if you do PSA test every 3 to 6 months, rectal exam once a year, because you don't really need a rectal exam at every visit, it's not going to change that often, and a 12 to 14, but a standard biopsy, we now use 12 in the Ottawa Hospital, biopsy in 6 to 12 months, and then every 3 to 5 years. So that was the protocol that we come up with. One of the more interesting things that's going on with surveillance and even in diagnosis with prostate cancer is actually the use of MRIs. So you might hear about multi-parametric MRIs. So it sounds like a very fancy term. All it means is that there are multiple types of ways that this has been done. So we used to just do a straightforward MRI. They would put you in the magnet and just measure how the atoms spin and all that stuff within the magnetic field. Now we give dye and we do different types of washouts of the tumor. So different areas, types of tissue in the prostate we'll wash that dye out at different rates. So we look at how it diffuses, we look at how it washes out, and they can map the prostate quite nicely. And we are so much farther ahead today than we were even 3, 4, 5 years ago with MRI technology, and it's just getting better and better all the time. We're hoping that we're going to get to the point where for active surveillance we might even be able to skip the follow-up biopsies and just do MRIs, but we're not there yet. But that would be great, because that would, again, eliminate a number of the harms. And I'm going to show you an example of an MRI. But just the concept of the surveillance and the tumors that you're concerned about. If you sort of picture the prostate sitting in front of the rectum here, and the urethra going right through the middle, there's kind of a horseshoe around the outside we call the peripheral zone. So that horseshoe is mostly towards the back of the prostate. That's actually where most of the cancers occur. So 90% of all prostate cancers occur in that horseshoe. That's the one that we can feel, and that's when we put the needles in, which come through the rectum, that's where the needles tend to go, that back horseshoe. We kind of ignore around the urethra and in front of it because that's not where most of the cancers are. And it also makes the biopsy a lot more uncomfortable and causes more blood in the urine when you go towards the front. So the problem is, if we do the biopsy of that horseshoe and we have a little bit of Gleason 6, what we've come to learn over the years is the bad cancers that are hiding from us are probably hiding in the front part of the prostate. They're hiding where the needle didn't go originally. So there's two things you can do to sort of overcome that challenge. One is you can just direct your next set of needles. So when you get your 6 to 12 month biopsy, the needles are just directed more anterior, as we say, or more towards the front, like towards the belly button kind of thing. So you can direct your cores up there better. And secondly, if you have access to a multiparametric MRI, you may be able to actually find something in that front part that you can target. So you're not just blindly putting the cores up front, you're actually targeting something that might show up as an abnormality. So I put in an actual picture of an MRI that shows that anterior tumor. And one of the issues that we also faced was, as seductive as this is, because you want to do this then to everybody that goes on active surveillance, we really don't know whether everybody would benefit from an MRI like this right off the top. So we've, in our guideline, the evidence really didn't support that either. There are no really good studies that say every guy on active surveillance should get an MRI. So what we came up with in our guideline was that an MRI is indicated when there are discordant findings. So in other words, if something just doesn't seem to fit, let's say a guy's got a PSA of 10 and his prostate is really tiny. It's like a 20 cc prostate, which is very small. That's about the size of a 20-year-old man's prostate. So that's, that's a lot of PSA for a 20 cc prostate versus the next guy who's got a PSA of 10, but he's got a 100 cc prostate. So a bigger prostate makes more PSA. So when we find a guy with a really small prostate with more PSA, even though it seems low, it's like 9 or 10, there's something discordant there. So that's a guy who in our practice would almost always get in a multiparametric MRI before his second biopsy. Because we think there's something, the chances that there's something more there is higher. Similarly, if we have a guy who's got, say, 5 or 6 cores out of 12 that are significantly involved, it's Gleason 6, so it's not that worrisome, but there's a lot of tumor in that prostate. We know that that is a marker for a higher chance of having 7 elsewhere, rather than just that 25% chance that we had talked about before. So in that case, we would do a multiparametric MRI. The prostate and the urine channel going through it, and then you see these nodules in the front part of the prostate, which are well away from where we would typically biopsy. The radiologist can then do what we call a fusion biopsy. Fusion just means using ultrasound and MRI technology, and the needle goes into that spot. So if that spot is not cancer, then we can be much more reassuring to the guy after his second biopsy and say, look, we don't have to work with this for 3 to 5 years. We'll see you back in 6 months with a PSA. So MRI is I think, the real up-and-comer in the world of active surveillance. And in fact, it's even being used more without as much evidence as we should have. It's being used a lot more as well for diagnosis. So you say, well, if it works in this part, What about if I show up with a PSA of 8 or 9 or 10? Why don't you do an MRI on me now? And then we'll do a targeted biopsy for my first biopsy. So if there's something in the front of the prostate, you'll hit it on the first go. I don't have to go through this whole process of one biopsy shows low-grade disease and I'm followed up with a second biopsy 6 months later. So that's again, a very seductive way of thinking, but we really don't have any evidence for that. That's outside of the realm of this guideline, but there are plenty of places who have no issues with resources, such as places in the US where they're doing MRIs now and everybody that shows up with an elevated PSA. Partly the guy that is seeing you for the elevated PSA probably owns the MRI machine down the hall to send you for the MRI. So there are other forces that at work here, but we don't have those resources. We cannot do that. So we've actually, until we get better evidence for the diagnostic piece, we would rather put our resources into this population of patients to try to make sure that if we think a guy has a cancer that's not going to get him, that we can be as reassuring as we possibly can and try to find out whether he really has a worrisome cancer. So that's kind of cool stuff, and you can ask me whatever questions you want after the end of the talk here, which we're coming close to. So our fourth recommendation seems a little bit, it's a little tangential, but basically, when you look at this whole literature...
After one.
Okay, thank you. 2-2 after 1. So there'll be no more goals let in on the Ottawa side, because it's never more than 2. So the one randomized trial in this whole field is in the 5-alpha reductase inhibitors. This is like using Avodart for guys on active surveillance. And there's some evidence that you actually can lower the chance that one of his early repeat biopsies goes up to a 7. But it's only 3-year data, so it's really not that helpful. Nonetheless, when there's randomized data, we have to include it in guidelines. So we've said that we think that it may have a role in men on active surveillance, although it's a very soft statement because we're not so convinced by it. And our final recommendation is that if you're reclassified, so this is the other big sticky wicket with active surveillance, is how do you trigger treatment? I mean, sometimes it seems pretty straightforward, right? You get a guy, a little bit of Gleason 6 in his first biopsy, and then some subsequent biopsy, he's got Gleason 7. Okay, that guy should go for treatment. But it's not so black and white, because there are times where you get upgraded just because you have a little teeny wisp of 4 out of 5. So the 7s are made up of 2 patterns out of 5. So 3 out of 5, and now you have a little bit of 4 out of 5, but it's such a small amount of 4 out of 5. The guy's feeling great. He's been cruising along on his active surveillance. Do you really suddenly change everything at that moment just because he's got this little bit of 4? Yeah, you do most of the time, but you don't necessarily have to. What do you do with the guy that goes from 2 cores to 8 cores, but it's still Gleason 6? So what we do is we then do an MRI and repeat a biopsy. Do you allow the PSA to drive this? So you're following the PSA along and it's starting to rise. What kind of PSA rise will indicate something really bad going on? And what we've learned is PSA is a terrible, the way the kinetics of the PSA go, is really a terrible predictor of outcomes in the long term in this situation. So we've actually really eliminated PSA from this guideline. We would say that the PSA is rising in any kind of worrisome trend. That's a trigger for reappraisal. And by reappraisal we mean consider an MRI and an earlier biopsy than you otherwise were going to plan. So basically what we felt was the most reasonable thing to say is that if your repeat biopsy reclassifies you to a 7, or if you get a significant increase in the amount of 6, you can consider treatment. But you should also just consider reappraisal of that patient if it's just increased 6. And we try to avoid a lot of the other really hot topics here that there's just no answer to. And you have to kind of individualize things a little bit. So you hear this terminology, just to sort of get you sort of in the state of the art of active surveillance, is we've gotten away from the term progression. It used to be when we started doing active surveillance, we would say, you know, the guy had a biopsy that showed 6, his next biopsy shows 7, he's progressed to 7. So that actually doesn't make any sense, right? Progression would imply that the cancer has gotten worse. But in fact, what we've learned is that we probably just hit the 6, the first biopsy, and we've now just hit the 7, which was there anyway. So there's no progression. It was just we found the thing that we wanted to find on the second biopsy we didn't find on the first. So we call it reclassification because it's really not true progression. True Gleason 6 progression we think is an extremely rare event. And if you look at a long-term data, it's probably 1 to 2% of patients will progress from 6 to 7 or 8. The guys that don't do well are the guys that really didn't just have 6 to begin with. They had 7 or 8 from the beginning, and that was what's driving the long-term outcomes. So that's actually the end of my talk. Happy to take questions.
How do you get a second opinion on the biopsy? Some people don't agree the first time or don't think that maybe the first analysis was right. How do we get, as patients, get a second opinion?
Okay, so there's two things there. Number one is, it's now built in, basically from CCO, which is great. I mean, I don't mean to badmouth CCO tonight because I did the surveillance guidelines with them. We do lots of other work with them. Fantastic organization. It's a little bit misguided on PSA. But so they've dictated, and this is now mandatory. If you have a prostate biopsy and it shows a cancer, it has got to be read by 2 separate pathologists before the first report goes out. So you already have a built-in second opinion. If you have an active surveillance biopsy, which shows a change, so let's say that the guy's reading it thinks it's a 7 now and it was a 6 on the prior, that has to go through a second reading by a separate pathologist. Now, the level of expertise might vary from place to place. So here in Ottawa, at the Ottawa Hospital, we have some really good, high-powered, well-trained, dedicated, what we call GU, or genitourinary pathologists. You know, Harvard-trained and other fellowship-trained guys that are really good. And so usually they'll be the guys reading it, and you'll get a second reading from a top-notch GU pathologist. And that's not to knock smaller hospitals, but they just don't have fellowship-trained pathologists. They often have a general pathologist who's also reading, you know, lung tumors and colon tumors and other things. But so that's the first thing, is they're all reread. If you really want a second opinion, there's 2 ways you can do it. One is you should be able to just ask for it. And when somebody asks me for it, once I go through the explanation that it's already been reread, if they still want the second opinion, it's as easy as my secretary sending a note to the pathology department, and they'll arrange for a repeat. Second option is if you have a particular place you want it read, like if you want it sent to Jonathan Epstein at Johns Hopkins, kind of the guru of all gurus of prostate pathology, then it can be sent, but you might get hit with a cost. Some of the guys in those situations to do a consultation might charge for it, and that's going to be patient-driven costs. And we have lots of other experts in Canada, like in Ontario, where you can get it read by a pathologist in Toronto, for example, with no extra cost to you. So there are multiple checks in the system.
One of your, I think the very first screen grab you had, I'm singing a medley from my Christmas album, but the very first screen grab that you had from the CCO site showed description of average risk patient, and then you said it made a jump to increased risk patient.
Yep.
And you described that there's no mention of the in-between, and I don't quite have a...
Well, there was. The only mention was in that little paragraph. They basically just say that, I can run back through this. They basically just say that the Canadian guidelines show no real evidence. So here.
Yeah.
So you see the average risk guy, they're calling,
yeah.
And they're talking about, so they talk about several categories. So 70 and over, men who probably are unwell, like if you have diabetes and you've had 17 heart attacks in the last 6 months, you probably shouldn't get a PSA test done. It's not going to help you. And then they talk, I think the rest of the folks are in this small paragraph here. Talk about the Canadian Task Force recommends against screening for all ages. So they're saying no, no, and no. and then they're saying no again. So it doesn't matter which group you're in, they're saying no. The only thing that they sort of bow to a little bit here, and nod their head to, is the benefit. So remember, they call it a possible small benefit, or they call it a small benefit. Here they call the greatest benefit from screening is in men 55 to 69, and that's based on the ERSBC study, which is that European randomized trial that showed a 21% reduction in death rates for the men who got screened with PSA. Does that answer your question?
It does. Is there perchance a political connection to Cancer Care Ontario taking that kind of a stand? Or is that a loaded question?
No, I think it's a reasonable question because, you know, there's two things. Cancer Care Ontario is, I mean, I don't speak for them. They don't pay me to do these guidelines. These guidelines are done because we think they need to be done. I think that the Ministry of Health strongly supports this kind of wording, right? Because we're in a real healthcare financial crisis, and if you can knock off some of the things that you think could be very expensive, and an esteemed body is telling you you can knock them off, then I think the ministry is happy with that. I don't think that necessarily means that they're pushing this agenda. I think they're just happy with the results. I don't know honestly don't know the political forces that drive the powers that be at CCO, whether there's crosstalk or not. I suspect not. I think the problem here is very similar to the problem with the other groups. And that is that on the American task force, the Canadian task force, and in the CCO group, 0 urologists, 0 radiation oncologists, 0 any physician who ever touches a prostate cancer patient, no input from those individuals at all in any of these recommendations. And, you know, when you look, CCO puts this on their website. I didn't even know it was coming. The GU lead, a guy named Tony Finelli, who's with CCO, he's at Princess Margaret. And Tony only found out about this once it was almost on the website. He tried to raise a fuss, but nobody wants to hear it. So that's the other problem that we face here, is that I think we've done such a bad job of over-treating and over-harming for too long that people no longer want to listen to the urologists or radiation oncologists. They all feel that we are driven by some lust to take out every prostate that exists or to radiate every man that exists. And you know, I think it's unfortunate, because I think that's in Canada, that definitely is not true. But yet we're painted with the same broad brush. They don't want to hear our opinion. They think that, just like if you guys go to the government, all they're going to hear is, these guys, you know, this is a lobbying group and they have their axe to grind, they have their own agenda, they're very biased, they can't see the forest for the trees. They're not going to listen to you, and they're not going to listen to us. They don't even want to listen to us. They didn't ask us. So, once again, here's another statement that's a policy statement that's going to drive the Ministry of Health, because that's what CCO does, that comes about with no interaction with those of us who treat and study and do research in prostate cancer.
That's scary.
We agree. So actually, it's interesting, in the US, there's I can't remember the name of the congresswoman, but she is, I think she's from a Southwest state. She's trying to enact a law to mandate at least one member on each of the US Preventative Services Task Force committees that treats that disease, that mandate that somebody, a clinician, has got to be on that board who actually treats that disease. So that'd be kind of nice if that law comes about. But again, you know, the pendulum's we're already way past that with PSA testing.
Dr. Morash, you're talking about CCO. What interaction are we guys having with the other provinces, and what are their views on this? Because I know we're driving it.
Right, so CCO is a very powerful voice in the country. Technically, it's just Ontario. I mean, the mandate is Ontario Healthcare and Ontario Cancer Care. But no other group in the country is producing guidelines that at this level. So in fact, like this guideline, I've been approached by ASCO. So you guys know what ASCO is. It's the American Society for Clinical Oncology. So this is like the world's biggest cancer society who would like to endorse this guideline. And so, you know, it's something produced in Ontario that immediately gets the attention of ASCO. And they've endorsed a couple of the other, I think you guys actually had Sean Malone come talk to you about some of the more advanced prostate stuff like the enzalutamide and all those other things, guidelines endorsed by ASCO. So I think the world really stands up and takes notice as to what CCO says, because we've produced such high-level work in the past, and much better than any other province. No other province is anywhere near CCO and this kind of stuff. BC is close. The BC Cancer Agency leads the way in a number of other ways, but not in guideline production. In fact, this guideline is going to become the CUA guideline. It is already, but so that tells you the power that CCO has. It's just one province, but it actually it's big, and it's because really good work is done.
Sorry, I have a question around the PSA screening. I was the first man in my family to be diagnosed with prostate cancer. My son's 27. When do you recommend, or what do you recommend for him in the future? Or when should he?
Yeah, so I think he probably should start to think about it maybe when he hits 40. And when I say think about it, I'm not sure he needs anything done until he's maybe sort of middle 40s. So if he's 27, you know, we're looking at 15 years down the road, and one would hope that we're much further ahead technologically at that point. Either we've got a better blood test, or we have some combination of a much better priced MRI, ultrasound, something that you can have where, you know, you can just get scanned and we know whether you're at risk. So I think hopefully he'll be facing a more clear decision about screening than what he would face today. We generally recommend sort of early to mid 40s, and it's based upon an interesting project. So in some of the Scandinavian countries, there was a project in the 80s where, in fact, I think it started in the late 70s, where they had a large number of young men put away blood samples, a number of different samples, and so there was no PSA testing in the 70s. So the beauty of this is now in the 2000s, when we can do PSA testing on that stored serum, we now know what the guy's PSA was back in 1978. And we also know what's happened to that guy over the last 35 years. So when you look at that data, it's really interesting. If you have a PSA in your 40s that's under 0.6 is the best number, but we use 1 to kind of make it a little more generalizable. If you have a PSA under 1 in your 40s, your risk of subsequent prostate cancer, significant prostate cancer, is very, very small. If your PSA is over 1, then it goes up, the risk goes up, the higher the PSA goes. So even though a guy in his 40s or 50s, we would call a PSA of 2.1 normal, that guy actually has a significant risk of having advanced prostate cancer down the road. It even goes, if you have a PSA of 3 in your mid-40s, you have 120 times increased risk of advanced prostate cancer. Not Gleason 6, advanced prostate cancer later in life. So it looks like there is some reasonable ability to predict your long-term risk with a sort of mid-40s PSA. So again, that data does not get on the radar of these groups that are making these recommendations. But I would say that's why we really say early to mid-40s. But it'll be a different world for him.
Do you have any symptom that you can tell your sons, the 2 boys, 39, 40, to look for, apart from having their PSA taken, starting at 44, yeah, as you suggest? Because my dad had prostate cancer, and I had it too, and
yeah. So symptoms are usually a lousy way to try to do early detection. So I don't really recommend people look for any symptoms. If you have urinary symptoms, it's probably due to benign prostatic enlargement and not due to prostate cancer. Although rarely it can be, and if it is, it probably means you have an advanced prostate cancer already. If your cancer is big enough to cause symptoms, you probably have an advanced cancer right off the go. So that's a bad sign. So that's rare. That's not very common. So really symptoms, I wouldn't recommend you ask them to look for any particular symptoms, because then, you know, the normal things we get as we're growing older, we're all going to think we have cancer, and I think it's just not reasonable. I think they should can be considered for screening around the age that they are. We have, the youngest guy that I've operated on is 39, and you know, we do have a significant number of guys in their 40s that are operated on, and usually they were screened for some other reason. Some is just lucky that their family doctor happened to do a lot of screening, or they had a heavy family history, or maybe they did have symptoms and they had a PSA checked. So the symptoms are not from the cancer, but the symptoms are sometimes the way in the door, right? So the guy goes to his family doctor because he's up at night 3 times, and it turns out he has prostate cancer because the guy does his PSA, but the getting up at night was not from the cancer. It just was the way that he got to the doctor in the first place. So I think screening them in their sort of early to mid 40s is reasonable, but I don't think I would talk to them about looking for symptoms. I think it's not helpful.
Just ask a simple question. I'm 78. I was removed when I was with 69, 70. It's been in more or less around 6 or 7 right now. I haven't had any radiation or anything of that nature. And I'm very, very pleased. I'm not sick or anything. So, is there any research work being done on what happens to these seniors that have never had, well, I've had removal, but no chemo, radiation, or hormones?
Excuse me, it's 3-2 Ottawa. Sorry, go ahead.
That's the type of news I like. So what are we doing with the seniors? I guess I'm the oldest here right now, 78.
So have you had, are you diagnosed with prostate cancer, or you're just a guy who's got an elevated PSA?
I'm sorry?
Have you had a diagnosis of prostate?
I had it removed when I was 70 or 71.
Okay, so you've been diagnosed and treated, and now your PSA is drifting up slowly.
Exactly.
Yeah, no, we have lots of people like you, and we usually just observe it. We look at a number of things. I mean, it gets a bit complicated, but we look at, if you had your prostate out, we can look at the margins, we can look at how extensive the cancer was, and that will help tell us what your risk of a significant relapse is in the future. We can then look at your trend of your PSA. In this situation, your PSA trend is far more helpful than in the active surveillance population. So if your doubling time becomes 6 months or less, then you're probably headed for trouble. It may not be for a few years, but you're probably headed for trouble. If your doubling time, I mean, it sounds like if you were treated 7 or 8 years ago and your PSA is 8, unless it started rising very recently, but if it was doing it over all those years, your doubling time is probably very long. And you can just calculate that quite simply. And if you can't do the calculation, just lots of doubling time calculators online, just put in a series of PSAs. So if you have a PSA doubling time at maybe in the range of 2-3 years or longer, then I think your risk of problems is low. So if you were 48 and your PSA was 8 and you'd had your prostate out 6-7 years ago, we probably would have treated you long before now, just because of life expectancy. I mean, it sounds discriminatory, but it's not. It's logical, right? We don't want to over-treat somebody who's not going to live statistically 15, 20 more years necessarily. So it sounds very reasonable. We all have lots of patients similar to you where the PSA is sort of rising very slowly over time. We've chosen to just observe it. So, yeah.
Okay, thank you.
What factor or factors, signs, tests would lead you to the first biopsy?
So that's usually PSA abnormality, and in some cases a rectal exam abnormality. So we have lots of, not lots, I mean, we have lots, but it's a small proportion of the men diagnosed who had a normal PSA, but when their family doctor put a finger in, they actually felt a nodule. And those are actually the worst ones. If you compare that to someone with an elevated PSA, but their rectal exam was normal, this other guy has a normal PSA, but an abnormal rectal where it's really hard. If that's cancer, that means that that tumor is big enough to bulge out of the prostate, and we can feel it. So that guy's probably further down the road than the guy with just the elevated PSA. And the other thing is that some of those guys with an abnormal DRE only, so rectal exam only, with a low PSA may have a higher grade cancer. Because sometimes the Gleason 9s and 10s actually don't produce much PSA. The cells in the glands are so abnormal, they're so far removed from normal that they lose the normal production of PSA as a matter of course. So we'll see people with some really awful prostate cancers with PSAs of 1 or 2, but they're picked up on a rectal exam. So it's usually a PSA, and it could be a rectal exam. There's rarely we do a biopsy for any other reason. You know, I have biopsied 1 or 2 guys over the years who just have these horrific family histories. You know, my father died of it, 2 brothers died of it, my uncle died of it, my grandfather died of it. I mean, that guy, I'm seeing that guy at 50, I'm going to do a biopsy whether I feel anything or he's got an abnormal PSA, but that's rare.
So do you think a randomized trial that looked at some of these factors that would lead you to biopsy is planned or in the future? Well,
the number 1 reason to biopsy is a PSA. And so there have been some big randomized trials done screening with PSA versus not screening. And we have those results. And unfortunately, different highly qualified people will look at those same results and come out with very different opinions. So for example, there was a large-scale randomized trial in the US called the PLCO trial that did not show a survival advantage to PSA screening. The problem with that trial was, so if you think about it, when you're randomizing people into a study, the computer's going to spit out 1 or 2. So 1, let's say they go to the PSA testing arm, and 2 is they're going to go into the no PSA testing arm. And the only way you're going to see a difference is if these guys get PSA tested and these guys don't. The US trial, 50% of the guys randomized to no PSA testing got a PSA test. So is it any surprise that 10 years later there's no difference between the 2 arms? Because you're really testing almost the same thing. You're testing PSA testing against PSA testing. So you're not going to see a difference. In the European trial, it was less than 20% got PSA tested if they were in the control arm. So that showed a difference in survival. So I think we have that data. The problem is just these are extraordinarily expensive trials to run, and they take 10 to 15 years to get you an answer. And I don't think there are any screening trials that are still underway right now or being started, because it's, you know, I think starting a big screening trial is, nobody's going to fund it. You know, we've got 2 big trials that are complete. We've got conflicting results. I think we just have to live with that right now. It's fine to come up with ideas for randomized trials, but if nobody will fund them, you're not going to go anywhere.
Hey, Dr. Morash. As you know, I went to Mayo Clinic this week, and before we came here, I shared the story with everybody. But on my journey to Rochester, Minnesota, I was going through customs in Toronto Airport. And the customs officer asked me, where are you going? Rochester, why? Mayo Clinic, for some specific test. He kept digging. I'm not sure if he had a personal interest in why I was going there, or to do his job as we became. I told him going there for a special test of prostate cancer. And he asked a question that very simple question. I couldn't answer him, but I'm not sure you can. I'm putting him on the spot. But he asked, what causes prostate cancer? kind of a very simple question, but no one really talks about what causes it, and I'm not sure if you know what does cause it.
No, so the answer is we do know a little bit and we don't know a lot. So, you know, there was a recent study that looked at all cancers, just published maybe a month ago or so. It's very interesting. Looking at the cancers, even the ones that we know, the genetic defects that lead to the cancer, if it's a hereditary thing or if it's a otherwise. In all the cancers where they looked at, it looks like about 2/3 can't be explained. So 2/3 of all cancers you can't explain by some causative effect. It's not like lung cancer. I mean, if you never smoked and never worked in an environment where there was secondhand smoke or lived with a smoker, you're really extremely unlikely to ever get lung cancer. So we know there's clearly a relationship. We know occupational exposures for bladder cancer. Smoking's a big one for bladder cancer. Prostate cancer is tough. So we think that there are some dietary factors that do influence it a little bit. And there's some reasonable evidence for that. Some of the most straightforward stuff is really epidemiologic studies. So if you look around the world, there are different incidences of serious cancers. So your chance of having a clinical cancer and maybe dying of prostate cancer in North America is very different than your chance of getting a clinical cancer and dying from prostate cancer in an Asian Pacific Rim country. So you think, okay, well, there's clearly, you know, different amounts of cancer. Well, there's not. If you look at autopsy studies in the Pacific Rim and in North America, is the same amount of background prostate cancer in both populations. So it seems something in North America is causing these to become clinical cancers, whereas there, on average, they're not. So if you follow populations of men who immigrate to North America, so it's usually the West Coast that come from the Pacific Rim countries, and you follow them and their offspring take on the same risk of clinical prostate cancer and dying of prostate cancer that we do, living and being raised in North America. So it's clearly not a genetic protection. If it was a genetic protection, you'd think there'd be fewer autopsy cancers there. And you'd think that when they move to another part of the world, they would maintain the genetic protection. So it's not a genetic thing. So it's clearly got to be environmental, and the easiest thing to point to is diet. So we think that there's something about sort of an Asian type of diet that's probably protective. So there's a reduction in red meat in that diet, or no red meat. There's a lot more sort of bright green, bright colored vegetables. There's more fish intake, more tofu, more plant-based estrogen intake. So the problem is, how is that practically useful for a guy here? So a guy comes to see me, he's 65, we find a prostate cancer. He does his research and he comes back and says, okay, I'm now a vegetarian, I'm eating tons of tofu, and this is great, like I fully support that. The problem is, the people that it helped started that diet their first meal, right? The guy who's 65 has 6.5 decades of probably bad eating. Doesn't necessarily have to be bad eating. It's not like he's had to eat a cheeseburger every day for 65 years, but you know, more fat, more red meat, etc. So really, what difference can you make at 65 or whatever age over the short term? I think if that guy's going to be around for 15 or 20 years, it's probably a good thing. It might reduce his risk of prostate cancer progression, maybe. He may reduce his risk of heart problems. He might reduce his risk of colon cancer. Or maybe he's just wasting his time because he didn't start this 65 years ago. I really don't know. So diet does play a role in it. There are some genetic prostate cancers. There are clearly some genes that have been identified that do cause these families with horrific amounts of lethal prostate cancer. But that's actually a very small percentage of the total prostate cancers that we see. And so, you know, I think for the most part, the struggle with the cause is how common it is, right? If you do an autopsy on guys who are 80 years of age, 80% of them have prostate cancer. Most of it's Gleason 6, but they have it anyway. So when the population is all going to get this at some point, how do you point to a causative effect, right? So it's a causative agent. So it's a bit of a tough one. We know a little bit about diet, we know a little bit about genetics, but for the majority of clinical cases, I don't think we really know why you have it. So that would have held you up in customs about another 10 minutes, I think. Yeah, they probably already weren't very happy with you anyways.
How are we doing?
I think we have another.
Get one more.
Sure.
I'm about to go through surgery on Monday. I would like to know the risks. My biopsy had 1.6 and 1.7 reading out of 10 specimens.
So the 7's driving the bus here, right? So in this case, we ignore the rest of that 6. It's the 7 that's driving your long-term outcomes, right? It's the highest grade that's going to drive things, and that's why you're going through treatment. If you only have 7 in one core, I think that you actually have a very good prognosis. Now, I don't know anything else about your case. I'm hoping your PSA is not 150 right now or something, so... 8, okay. So, assuming no other surprises in your case, it sounds like I agree fully with you going through treatment. Any of the treatments are reasonable. Surgery is clearly the best treatment. But radiation is perfectly reasonable as well. So I think you're on the right path. Nobody wants to have this kind of surgery, that's for sure. And there may be some trade-offs, and I think the big risk trade-off for you, I'm sure this has been discussed with you already, but they're quality of life things, right? They're potential bladder control issues and loss of erectile function. And so, you know, for the average guy who's sort of around 50 or 60, loss of bladder control occurs in about 5% roughly. And that can be anything from just a pad a day to 5-6 pads a day. Some of those guys we can treat later with slings and other things to fix them, but they will require other treatment, and some of those guys will not regain their control and are not going to do well with any other treatment. So it still leaves you with a 95% chance that you will regain your control at some point and get back to pretty normal voiding. Your risk of loss of erectile function is going to depend upon a number of factors. So one is age, 2 is pre-operative functioning. So if you have lousy erectile function beforehand, it's not going to get better with your surgery, that's for sure. And if you've got good erectile function, it will go down a bit. But if you start really good and it goes down only a little bit, then it's still pretty normal at that point. So those are really the two things. There are lots of other risks to the surgery, but they're sort of general things, you know, heart attack, stroke, and blood clots, and pneumonias, and things like that. But I think it's these quality of life things, and it's kind of an interesting, it's an interesting dynamic, because the thing is that I think for most people when they're going through their treatment, in order of priority, they want their cancer treated, number 1. So they want a good outcome. They want to be 10 years down the road with an undetectable PSA. They want good bladder control, and then they want good erectile function. That's the usual sequence for people, 1, 2, and 3. Sometimes they're different. Some guys actually would prefer to have good erectile function and don't care so much about the urine control. But that's an individual thing. But there's just to keep it in mind, what happens is the erectile function sort of gets shoved aside a little bit. I think you really have to have your head wrapped around that though. So what ends up happening is, so people say, okay, I've got a cancer, I got to get this thing out, I want to live. I want to live with good bladder control. My erection's okay, look, it's great, I love having them, but that's the one thing I think I can sacrifice. And statistically, that is the thing that you're more likely to sacrifice. What happens is, when the dust settles here, and a year or a year and a half goes by, you've regained your bladder control, your PSA is undetectable, and you sort of, someday you kind of look around and say, hey, you know what, I'm okay. I'm alive, I don't have cancer as far as anybody knows. Bladder control is pretty good. And then, number 3 becomes number 1. Right? Then the erectile dysfunction becomes much more important to you. So, you know, that's a really tough one to deal with, because we're pretty good at talking about cancer. We're pretty good at bladder control, because statistically you're likely to regain it anyways. But erectile dysfunction is a tough one for patients and their partners. And I think people that think they have good communication, I think many of them don't actually have good communication. And the guys come in and say, yeah, I talked to my wife about it, and da-da-da-da. And I'm not really sure how that conversation went a lot of the time. I think some people do have a really good open communication. But when you get the wife in for the next visit, you know, well, he didn't really say anything to me, or, you know, it can be a very different dynamic than what the guy was letting on. So, I mean, there's nothing you can do about it, but just, I think it's important to understand that priorities and side effects change over time. And that one comes to the surface later on as a big deal. So what I would suggest is, if you're offered an aggressive form of penile rehabilitation, so in other words, when we get our patients back, we talk about the pathology, we get the catheter out and all that early stuff. Sometimes what I say to patients is, look, I can put you on some daily dose of Cialis or Viagra. We can even start you on injections. I can refer you to a guy that can help you with that, whatever. And they'll just say, no, look, right now I just want to regain my bladder control, and, you know, I've just come through a cancer operation, I want to get back to work. And that's all great, but the problem is that he may not regain as good a control, as good a erectile function later if he ignores it now. So keep them all on your plate, and if you're offered a more aggressive approach right away, and it's important to you, don't let the opportunity go by, because the best results are if you really push it early. And sometimes it's gone no matter how hard you push it. So, but I think you can increase your odds if you really push it early.
Dr. Morash, I don't think on behalf of the folks here, let's we have been looking forward to you, and I have not had the pleasure to meet you, so that's great for me. But I know you're well known to many here. But I don't think we could have done better tonight by having the depth and the breadth of a conversation from somebody who knows that the business we're in well. I'm blown away, frankly, by because, you know, this guy talked about a whole range of stuff. I mean, you know, sometimes the conversation in these situations can be pretty narrow. And to have had the depth and the breadth of conversation, I think has been just super. And I want to thank you very much. And of course, I want to say as well, Bill Dolan, our past co-chair, dialogued extensively with folks at the Ottawa Hospital to make this possible. This is our third speaker in the speaker series that we're so blessed to have. So Bill, come up, please, and we have a little token of appreciation. So thanks again very much, Dr. Morash. It's been a pleasure.
That's my pleasure. No problem. It's 4-4, unfortunately.
Dr. Morash, we want you to remember us as a bunch of sweet old guys, not as a bunch of sour old.
What's this old thing?
So this is a token, a gift of our appreciation of your coming tonight. Thank you very much. Thanks so much.
Thanks.